Welcome to Sniff This, the podcast where we pull back the bed sheets on skilled nursing facilities, educating, entertaining, and occasionally risking being reported to HR. Awesome. Super excited to be here today. Another episode of Sniff This. I'm with two of my really good friends, actually Noah and Dr. Anderson. On this episode, we're going to dive into some difficult topics, I think, but really important topics, especially as we look at management daily and acute management of patients in a skilled nursing facility. So we'll get rolling. Like to welcome Dr. Aaron Anderson. He's the Chief Medical Officer for Gadzoom Health, which is one of our partners with Vital Care. But go ahead and introduce yourselves. Tell us about your background, your training. How'd you get in the space? Why are you still here? What keeps you in the space?
So thanks for having me. My name is Aaron Anderson. I'm a physician. I went, my background is, my medical training started at Weber State, actually, here in Utah. And then I went to the University of Cincinnati, go Bearcats, for medical school.
Okay.
And then I did a residency and a fellowship in sports medicine, actually, and made my way to Washington, where I practiced sports medicine for about 10 years.
Awesome.
At Vancouver Clinic, covering sports teams and taking care of it, mostly outpatient stuff. And so I fell into the sniff space by accident, really. I had friends that were in it and convinced me that this was a good idea. So we moved back to Utah and started Gadzoom Health, which is a medical directorship taking care of patients in SNFs and nursing facilities. And we came back to Utah about 4.5 years ago and started the company. And I had to it was a little like getting back on a bicycle, I feel like, the medicine, because I trained in family medicine. So I have a background in this. So it was just like getting on a bike after not being on one for a while. But we've been doing this for the last 5 years and love it. It's been great.
Yeah, that's awesome. It's a great partnership that we have with Vital Care and Gadzoom, and you guys are growing really quick. So Utah, you're in Nevada, you have a heavy presence in Texas now and growing
Dallas,
pretty quickly.
Growing pretty fast in Dallas.
That's awesome. Good. You guys have a great service they offer. So I was like intrigued from sports medicine to like skilled nursing. That's like two different sort of wide ranges. But what is one of the things that like drew you to the space and like skilled nursing and like has kept you versus like just going back to the sports medicine side? I know you do some of the business side too, which is probably some of the appeal, but.
Yeah. So, it's basically the exact opposite of what I was doing. I was taking care of outpatient medicine, fractures, lots of kids, but a lot of older adults with bad arthritis, fractures, those types of things. And that's a lot of what we deal with in the SNF is taking care of those older adults. And so I think the appeal was getting into a different side of medicine. I'd been doing that for 10 years and maybe got a little, not bored, but a little
that's fair to
tired
say.
of it maybe, and wanted something new, maybe a new challenge. And so this opportunity came up to work with really great people, number one, but also in a space that was the reason I went into medicine in the first place, into family medicine, was to take care of people.
Right.
And this is it's a great space to do that because there's just so much need.
Yeah, absolutely.
And so that's what's kept me going in it.
Awesome.
Growing, we're expanding our provider line. We have about 50 providers now. And so managing all of those is kind of a big deal, but also staying connected to the patients is number one.
Yeah. No, I always tell people, because I don't think the SNF world is like the sexy place to be.
Nope.
In terms of like a provider, that they're actually losing providers pretty rapidly, and it's hard to retain some of that. But I always tell people there's an opportunity to make such a big difference because there's so much improvement to be made. So that's awesome. Thanks again for being here. Super stoked. We also have my good buddy, Noah Dobson. Yeah. We met in PA school and we kind of stuck together ever since. And he's kind of on the front lines. You take hundreds of telehealth calls every month, which is impressive. So Noah, tell us a little bit about you, your background. How did you land here? And
so again, background mainly started in family medicine as well, urgent care, and then have been from Vital Care from its infancy and has seen it kind of grow, and am right there with a lot of these other providers taking calls for these skilled nursing facilities, and it's been a great opportunity to have a population that is a little bit different than what comes in outpatient urgent care. A little more internal medicine, a little more comorbid conditions that we really get to like experience, treat, and make a difference for these patients' lives.
Yeah. Thanks, Noah. Super stoked to have you here. Hopefully we'll have you on many episodes coming up. But one of the things that we ran into is because the space is so nuanced, is like there's not a lot of education material focused in this space, which is really the whole impetus of this podcast, is like, how do we get more information about the space as unique it is, but also from the medical side. And so Noah does a lot of our training, and we're going to talk about 3 topics today that I think really, from like the medical treatment provider, rounding provider perspective, is really hard. So we're the ominous UA, UTI, the H&H, when should we be nervous about that when a CBC comes back and their hematocrit or hemoglobin's low? What are we doing that from an acute setting? And then the electrolytes. Like a lot of our patients are sitting in these spaces where their electrolytes are already out of whack. And so what's really kind of the space we want? So we'll tackle the heavy one first. And then I have a surprise for you guys coming up, which I'm excited about. We'll do our sniff segment, but really, Dr. Anderson, talk us through kind of your philosophy and approach to UTI management in a sniff, which is so convoluted and difficult in terms of when do you test, when do you treat, when do you just watch? Like, what's your approach for that? That was a heavy one. So
I was going to say,
we're gonna like
you could kind of write a book on that,
Yeah.
I think. And so I think to start when talking about UAs and UTIs is from my standpoint, it's really not like a super difficult problem.
Okay.
Like, I think a lot of people look at it and go, I don't know when to treat, how to treat, what to treat, which criteria to use. And so I think you can simplify this down. A UTI is no different than really any other infection. Right?
Okay.
So it's a bacterial infection that happens in the urine. And it can change in different populations, whether you have a catheter or not, or whether you're immunocompromised or not. But when I look at it, it's just an infection. And I think the bigger thing is realizing how to use the tools to get to that diagnosis, and then when to use those specific criteria, which is what we come across a lot in the sniff. So when I look at a urine infection, the first thing I look at is symptomatic versus non-symptomatic. And I think that's a big thing that always comes up is when we have somebody that has like altered mental status. And I think this is a really common situation in the sniff. Somebody has altered mental status, and so the first thing they do is order a UA. And I think that's where it becomes a problem, is because now we're testing an asymptomatic patient. And not completely asymptomatic, right? They have a symptom, and their symptom is maybe lethargy or altered mental status, but that's not a symptom of a UTI. So I consider that asymptomatic testing.
Okay.
And that's where I think we run into problems most of the time, is asymptomatic testing.
Right.
And the reason that that's a problem is because it's very difficult to get like a perfect sample of a urine. And so there's oftentimes bacteria in the urine that are just bacteria from the skin, normal microbes that just kind of live on the skin, get into into the urine. And then when we test it, we see those. And that's where it creates a problem, because then you get something back and it might have 1 or 2 or 3 more organisms. And do we treat that? And the problem there is that we tested incorrectly. We tested an asymptomatic patient.
And because the colonized is coming back positive, and
right.
Then our hands are tied.
Then our hands are tied to then, well, I guess we have to treat it because there's some bacteria in there. And so we end up treating it, and then later realizing that we probably didn't need to treat that. So I think that's where the confusion comes in with these is how we test. And so I do think that it bears kind of going into the different criteria that we use in looking at UTIs. I assume most people know what the criteria are. There's McGeer criteria. It's McGeer with no R. I hear everybody says McGreer for some reason. I don't know why. And then there's a couple NHIS, I think, has a criteria, but I believe the most other common one that we see is Loeb's criteria.
Loeb,
L-O-E-B.
I'm always worried saying it wrong. I'm like Loeb or Loeb. Loeb. So okay, L-O-E-B.
Only
Loeb.
providers are going to make fun of you if you say it wrong. So
well, those are the people I'm worried about.
Right.
Like, yeah.
And so I think that it's good to understand the difference between. So McGear's criteria was built for surveillance purposes. Basically, look back on have we treated these infections appropriately or not. And Loeb criteria was built for treatment decisions.
Okay.
And so oftentimes we see them used incorrectly. And if you try to use McGear criteria to treat an acute UTI, what you're going to end up with is having to wait for a culture, because that's one of the things in McGear's criteria is that you have to have so many colony forming units, CFUs, in the sample. And if you wait for that culture to come back, I mean, cultures can take 3 to 5 or more days. And by that time, the patient can get really sick, uroseptic, end up in the hospital, and have a lot of problems. So we look at Loeb criteria, which are strictly about symptoms. So they have to have acute dysuria or a combination of a fever with other urinary symptoms. And that's good enough to actually start treatment on the patient.
Without like testing, like taking a UI?
No. We'd still
after
do
UI positive. Okay.
After doing a UA. So we'd still do the UA in that situation, because then you're testing a symptomatic patient.
Okay. And are you always sending a culture when you get into UA, or what's your like?
It's typically reflex with those labs to get the culture or get the UA. And if the UA comes back with anything positive, they'll send it away for the culture. And I think that's helpful. If you really think they have an infection, the culture is the way we determine whether we put them on the correct antibiotic or not. Right. So that's why we use the culture. And that's where McGear's criteria can actually be really helpful, because it can look back and say, yes, you treated these patients appropriately versus inappropriately.
Yeah. Like number one call, 2 a.m, nurse is calling like, hey, Chance, this patient's confused and their urine smells funny. And I collected a UA for you. And you're like,
congratulations.
Ugh. Yeah. Like urine, foul smelling urine, or like odd colored urine is not a symptom or not a criteria for testing. But for some, I think in a cultural perspective for these nurses, they're like, oh man, in the past they were altered. Something's wrong. It smells bad. Their urine smells horrible. Like, we get a UA. And so they like instinctively are just calling a provider and saying, hey, can I get an order for a UA? And I'm always like, wait, time out, pause. What are we doing? But I think it pretty common practice for a lot of our providers, if they're have altered mental status, and Noah can correct me if I'm wrong, but they're just reflexing to ordering a UA. And then we see you have a positive UA, they're altered, then we have to do something about it. So It's a little bit of a trap.
I mean, I don't think urine smells good ever.
Yeah.
I'll be honest. Like, so when they say
just
foul
wait
smelling,
till our sniff test. Sniff test later on.
When they say foul smelling urine, to me, it's always like, well, yeah, that's urine most of the time.
That's a good point.
And so I think, and that's where education can really be helpful. If all the nurses knew the Loeb criteria, and they're simple criteria, if they just recognize that, hey, we got to ask about, because a lot of times we're not asking the right questions.
Yeah.
Right. As providers or nurses. Do you have dysuria? Does it hurt when you pee? That's a great starting question, because if the answer is yes, then well, that's different than just altered mental status and foul smelling urine.
Gotcha. Is there ever a time that you're like pulling the trigger right away where they have dysuria and now they're altered and they have a fever and now you're worried this is like going to septic? Are you pulling treatment right away to like treat them, or are you still hesitating to get that UA back? Is there ever a time? I don't know if there is, but
no, I think so. You can make a clinical diagnosis.
Yeah.
And I think that's, I mean, one of the big things that I think we're probably going to come back to a lot in this discussion is it's very patient dependent. Mm-hmm. There's no like absolute where you have to treat always in this situation.
Yeah.
Or with this lab, you know, if you get this number back, this is, you know, it equals this. Because it's always patient dependent. So there's going to be certain situations where maybe you know a patient really well and they have had lots of UTIs. They've ended up with urosepsis in the hospital before. You're going to be more likely to pull that trigger when they're having acute dysuria, telling you they have a UTI, but we don't have the UA yet. So in that kind of a situation, yeah, we'd probably pull that trigger. in somebody else, in a female who hasn't had a lot of history of that, who's relatively healthy, they're stable hemodynamically, in that kind of situation, we might want to wait for the UA. Put them on some pyridium, something like that, to kind of calm down their symptoms, get the UA to make sure we're treating the right thing. Because you can have these symptoms without a UTI, right? Dehydration. Very commonly, it causes changes in the urine color, changes in, it might feel a little different when they
altered a little bit.
And so it's probably not right to pull the trigger in that kind of a situation right off the bat until you get some of those results back.
Awesome.
And to kind of piggyback on that question, so I know you mentioned pyridium and consider dehydration. If they're like kidney function isn't good enough for pyridium, do you have any other tools to like intervene with while you're waiting for the results of the urinalysis?
Yeah, and in those kinds of situations, that's a great question. I think assessing that hydration status, getting them on some IV fluids can be really helpful with that. That can help clear up a lot of the symptoms that they have. And as far as medication-wise, if their kidney function isn't good, I mean, you can use normal analgesics, like you could use Tylenol and things like that. But I think correcting the hydration is probably the primary thing.
Awesome. I had another mentor, and maybe this like steered me wrong, but it got like pounded in my head where if I order a UA, you should order a CBC. Because then the white count doesn't come back and the UA is positive, then like his kind of rule of thumb, and that is you wouldn't treat. Obviously, there's like, again, the LOPE criteria would maybe speak otherwise to that because you have some sort of indication to test. But like if a CBC is normal and a UA is positive, in his mind is like, well, they're colonized and everyone has bacteria. Like any other like falsehoods, I guess you could speak to in that regard, or would you give everyone fluids? Like the theory of thought would be everyone probably needs a little bit of fluid anyways, right? Or
no, you can be hypervolemic and heart failure, and there's good. So I think, again, kind of going back to this, there's no every time or everyone.
Yeah.
So I don't, your mentor had his reasons. I wouldn't necessarily order a CBC every single time. Like that just doesn't make sense. I would take that on a case-by-case basis. That's why we evaluate the patients to begin with, is so that we can kind of make that determination. Do we need a CBC in the context of that patient?
Yeah.
So I think that's a falsehood that everybody needs fluids, because no, like there's a lot of situations where you give them fluids and you throw them into heart failure. Yeah. And now you're dealing with a whole nother problem.
Yeah.
So I think those they need evaluation. That's where, our jobs, AI can certainly help our jobs, but it's probably not going to take our jobs, because we need to evaluate a lot of different things that AI can't evaluate. And so evaluating the patient, talking to them, examining them helps you kind of figure out then what tests need to be done.
Awesome. And then as you come back to UA, you've done all the right things, it comes back positive. Is there anything you're reaching for that's like your go-to treatment for UTIs, or what helps you guide that decision? And before you get the culture and sensitivity back, like what's helping guide your decision?
There's standard first, second line, third line treatments. Yeah. Macrobid is kind of the go-to for the standard UTI that's not associated with a catheter. 5 days for a female, 7 days for a male. And so that's based off antibiotics, which, just kind of show like the relative prevalence of certain bacteria in urine. So that and Bacterium are kind of your first line treatments, with things like Cipro and other drugs being more second line treatments for depending on how those come back. So I'd say 9 times out of 10, I'm reaching for Macrobid first. Yeah, personally. There's a few that we try to stay away from in the sniff. If you pull up like open evidence or up to date, fosfomycin is a popular choice because you can give it as like one dose.
It's one and done.
But for an older population, it can cause some issues. And so I try to stay away from that.
Gotcha. Yeah. The whole like point of this podcast is there's so much variability. And there tends to be some subjectivity in this treatment testing process. And I think it's gone a little overblown that people are like so worried and nervous about it. And then you have all these like other treatment options that are creeping in, but really it comes down to, they're symptomatic, do they have a catheter or they do not? And based on those treatment criteria, like McGear,
McGear, there you go.
Dang it. And Loeb, then you're like choosing some of those decision making, but trying to get everyone on the same page can be a little difficult because patients are all different too, and needing to treat the patient, I think, as you well stated.
Yeah, and there's external pressures. The building may have a lot of infections, and so they're trying to like not suppress treating patients, but limit, try to be a little bit more judicious about antibiotic use. And certain buildings may have a propensity to have more infections just because those can come about from a lot of different reasons. Again, hydration status, pericare is a huge one. And so if you don't have well-trained CNAs who are taking care of these patients, you're going to end up with a lot more infections. So good education for the nurses and for the CNAs to help with what we can do for prevention is really important.
Awesome.
I think another question I've experienced since being a provider is some of the patients are like, oh, the 5 days of macrobid wasn't enough. Are you seeing any evidence that supports extended duration of antibiotics for these acute cystitis infections?
I think the standard practice is still 5 days for a female. But this again goes back to the situation where certain patients may not do well with it. And I think what we may be missing in a lot of these situations is actually going back and looking at that culture. Sometimes we put them on macrobid. Okay, they're treated. The culture comes back. Maybe you never see it. Maybe it wasn't covered by macrobid. Right. And so I think that's one of those key things is macrobid for 5 days is typically going to do it unless they have a bacteria that's not covered by macrobid or that's less covered. So they're getting suppression instead of elimination of that UTI. But if we're not checking that culture, then we're not seeing that we should have switched them to something else.
Yeah. Which I guess is another good case to take the culture and sensitivity. My other favorite 3 a.m., 2 a.m. call is the patient's like, I have a UTI. Mm-hmm. This is how it feels every single time. And you're trying to support that customer service side and listen to them, and they know their body the best, and that's what we're always trained. But they're otherwise asymptomatic, but in their mind they're like, I'm a little off. This is what it feels like every time. In that case, I'm always feel like I'm pushed to order UA as well, just because I'm like, that's not one of the criteria, but Susie definitely feels like she has a UTI, even though overtly there's nothing. And I always feel like I'm on the wrong side of that decision making, because I'm like, I'm doing it for Susie because Susie's going to complain to that poor nurse, and that poor nurse is going to get upset and blah, blah, blah. So I tend to, maybe this is I feel like I'm confessing to you guys. This is a time when I'm ordering UAs maybe inappropriately. I don't know if you run into that or.
Yeah, I mean, I agree with everything you said, minus the fact that I don't think we're a customer service industry. We don't give patients what they want necessarily. Yeah. We give patients what they need.
Then your ratings are going to be horrible.
Yeah.
Yeah.
Yeah. I don't really believe in rating. Again, physicians, it's nice to be nice.
Yeah.
Right. That's great. And it's good to have a good bedside manner. But in the end, we're not here to give patients whatever they want.
Yeah.
And if you do that, then you're letting them basically you're discounting all your education and saying, okay, I'll give you whatever you want, but that's not the world we live in. And so I'm willing to take that little rating hit every once in a while, just because I feel like I'm going to do what's best for the patient. And if it's not in the best interest of the patient, if I think it's going to hurt them in the end, I'd rather take the rating hit than just acquiesce to that.
No,
and maybe that's not a popular decision. I don't know. Boo. Yeah. Boo on me. But I think that needs to be understood, is that we're not providing wants, we're providing what's needed.
Yeah. I really, at the end of the day, I think documentation is really important. Your medical decision making really is important. And this is what I stress with all of our providers as well, is as long as your reasoning is sound and it's based in good criteria, good questions, then you'll be on the right side of that decision making, because then you can support sort of your decision process. And it comes down to making sure we're following our training, we're documenting appropriately, and we're talking to the patient and to the nurse and doing the right thing. So
yeah. And I don't think in that kind of a situation, necessarily ordering a UA is a bad thing to do, right? Because maybe that patient knows herself very well and better than you do. And maybe that is how she experiences UTIs. And so ordering a UA may kind of be the middle ground there, where you're not being mean and just saying no, but you're still addressing the concerns of the patient.
Got it. I was just getting it off my chest. It was like confessional here. Dr. Anderson, we're good. We're good to go.
You're absolved.
But I think we've spent a ton of time on UAs, and I like glanced down at your watch. So I know we've been at this for a good 20 plus minutes. So we might just focus on the UAs today, because there's so many other things we can do. But I want to leave time for like my favorite part of the podcast episode, especially
which was a surprise to me. I didn't know that this was
good. I want it to be a surprise, but you guys get a smell. So it is sniff this. So you get to try to guess what the smell is. To be fair, I didn't tell Noah what these were either. So we'll give you two different smells, and you guys can maybe hold your guesses until the end, but I've been nice.
I think you handed him the nice smelling one first, right?
Yeah. I think I got an idea on this one.
Okay.
Well, it doesn't have a real strong smell.
We'll take a stab here in a second. I was nice. I was like, this might be the one episode to bring in a urine sample, but I held back, guys. I like you guys too much.
Okay. You have guesses?
What do you got, Noah?
On the first one, my initial guess was Hibiclens, but then I got a cherry whiff after. So some sort of cherry medicine.
Yeah, I was going to say like Robitussin is what it kind of smells like.
Even more simplified, cherry Tylenol.
Cherry Tylenol?
Yeah,
because
I got liquid Tylenol.
I got the cherry as well. It did look like Hibiclens, but it's a little cherrier. I have to smell that one again, because
That almost smells like, tis the season, but peppermint.
I was going to say like mint gum. It kind of has like Orbit, but just like a really mild.
All right.
Oh, but I want to say it also has that medical smell too.
Yeah. I wouldn't let you guys off easy with just peppermint.
No, it's got to be some sort of cleaner. I would guess it's a cleaner.
Well, you guys aren't in the trenches anymore. It sounds like it's Miralax.
That's Miralax?
You'll probably get it now.
Okay.
I think it is like a mint, Miralax, but it's Miralax. So good thing you guys don't need that yet. And you're obviously not administering that right now.
And if I was going to take it, I'd mix it with some Gatorade.
There you
go.
So. Yeah. But super grateful for you guys. Go ahead.
I was just going to say, I'm going to go home and smell all my medicine bottles now, so that I know what I'm getting into.
It's just a fun part of what we do for Sniff This. But
yeah, love it.
Super grateful for both of you for your expertise and your time being here. I know taking away time from the things you could be doing. So super happy about our episode today. We didn't get to like H&H's, and we didn't get to like electrolytes, which are also huge like topics to discuss, but important topics. But I think
again sometime.
Oh, you said it. So we'll have you on again, but grateful for both of you, and we'll look forward to our next episode of Sniff This. Before we conclude, huge thanks to our sponsor, VitalCare Connect. Whether you're burning the midnight oil or just trying to survive another 2 a.m. call, VitalCare Connect provides on-call medical director support whenever you need it, nights, weekends, and holidays. With coverage nationwide, they're leading the way in post-acute care, elevating quality, expanding access, and supporting well-being for all. Learn more at vitalcare.org. Thank you for joining us for this episode of Sniff This. Share this show with your favorite CNA or anyone who's survived an all-staff meeting fueled by cold coffee. Until next time, I'm Chance. In skilled nursing, if you sniff something, say something.